Andrea, puoi chiudere? Dear friends, buongiorno. Good morning in US and South America. Good afternoon in Europe. Good night in China. We will end week 6 with a bang. And you saw the program of week 7 this coming week. Also, as I promised, I am presenting you the program of the final week, week 8. So let me briefly share the screen. Week 8 is going to be the last week, and is going from May 18 to May 21st. Topic will be ethics, sleep apnea, and temporomandibular disorders. And the speakers will be Peter Greco on Monday, Amaio Hall from England on Tuesday, Ambro Michelotti and Jacopo Cioffi from Naples and Toronto. And the final lecture will be Martin Palomo. So ethics will be the topic of Peter Greco. Then Professor Amaio Hall, Dental Sleep Medicine. Beyond teeth, what do we know about pain and dysfunction? Ambro Michelotti, University of Naples, Federico II, and Jacopo Cioffi from Toronto. And then the final lecture is sleep apnea and the orthodontist. So I want to remind you to use the question and answer button to facilitate the work of the moderators. And if you have any question that you particularly like, you can use a like button to emphasize the question. And without any further ado, I hand over the floor to Anne to introduce today's speaker and moderators. Anne?
Thank you. Well, welcome. Happy Thursday. I'd like to introduce our speaker, Mohammed Masood. He completed his orthodontic specialty and training and earned his doctorate at the Harvard School of Dental Medicine. He received the Joseph Henry Award at the school for clinical and research excellence. And he also was awarded the Harry Sitter Award from the American Association of Orthodontists. Dr. Masood is a diplomat of the American Board and has served as an examiner for the board. In addition to practicing in private practice for over 13 years, he was the clinic director, the orthodontic clinic director at the Boston University Henry Goldman School of Dental Medicine, and he is currently the director of the orthodontic program at the Harvard School of Dental Medicine. Mohammed holds 3 patents, and he's published over 20 papers that he has presented nationally and internationally. Mohammed is very well known and has done a lot of research in growth, and is going to talk today on considerations and management of Class 2 patients. We have moderating for us today from the Angle Society of Europe, Patricia Olbach, and we have moderating for Angle East, David Musich. Without further ado, Mohammed, the floor is yours.
Thank you, Anna. It's an honor to be introduced by one of my faculty, and I appreciate that. And I want to thank everyone that's been involved in organizing this meeting. Can you see my screen okay?
Yes, we can see it.
Okay. All right, thank you. Yeah, I want to thank Renato, Uta, and everyone involved in this. It's greatly appreciated, and it's a huge service for the community. So today I'm going to talk about considerations in the management of Class 2 patients. And I modified it a little bit based on what was covered the last few days to kind of try to tie it all up and tie it all together. So I'm going to cover these considerations, and it's a clinical presentation. So I'm going to show some cases. I'll show a little bit of research, but it'll mostly be cases to kind of give examples of these considerations. So we'll start out with growth and preventing dental compensation and how they relate to each other. So I'll start out here with the Cochrane review. So The Cochrane review that Dr. O'Brien is involved in, it has two parts to it. And the first part gets covered a lot. The second part doesn't seem to get enough attention, or I think it's actually the more interesting part. The first part covers the early treatment. And all those studies, and it's nice when you see different researchers reaching the same conclusion. All the studies consistently show that there's no real advantage to treating class 2 patients early. These studies were never designed to show whether or not functional appliances or headgears work. They were designed to see whether there's a benefit to treating early versus treating late. And that's why there was no untreated control. The patients that served as an untreated control for the first phase, all of them got treatment in the second phase. And that second phase of treatment often involved headgears, extractions, rubber bands, and sometimes even functional appliances in the second phase. So I think they're great studies at looking at the question they were designed to evaluate, which is whether or not there's an advantage to early treatment. The second part of the Cochrane review looks at studies that treated using functional appliances during the growth spurt. And that shows a slightly different picture. There are two randomized controlled clinical trials that looked at treating during the growth spurt. And both of them showed that there was a skeletal advantage to treating during the growth spurt. So most of you are familiar with the forest plot, and you can see that this is comparing functional appliances early versus late. And there was a difference after the first phase, but when you followed them up till after the control group got their second phase of treatment, that skeletal difference was no longer statistically significant. But when you look at the studies that looked at treating during the growth spurt, both of them, randomized clinical trials, showed that there was a skeletal advantage to treating during the growth spurt. And since that Cochrane review, there is a systematic review and meta-analysis that came to similar conclusions. The first group of studies all looked at treating early, and they all came to the same conclusion. And the second group of studies showed that when you treat late, you do have a skeletal advantage. And this looks at mandibular length. And there was a relatively recent study that came out after the Cochrane review, Martina et al., when she looked at mandibular length changes, comparing functional appliances to untreated controls, and there was a statistically significant difference in mandibular length, and mandibular length change, as well as ramus height change. Other factors related to growth that I look at are based on Frankie and Bechetti's study looking at the gonial angle. And when the gonial angle is below 125, that usually indicates the patient's going to be a good responder. And you want to start during the growth spurt. I think a hand wrist radiograph is more accurate than a cervical vertebra. I want to start when the sesamoid appears and the patient's just starting capping. And this study looked at other, cephalometric measurements like the mandibular plane, and they weren't predictive of who was going to respond well and who wasn't. Another thing that I look at on a Ceph, and I couldn't find any studies that this is just my observation, is that when the chin leans forward, when you have a forward extending chin, those patients seem to respond a lot better to growth modification. The only thing I could find about that was Ramzi Haddad and Joe Ghaffari's study, and they called it chin extension of the cervical mento-cervical angle. And they found that the more acute that angle was predictive of the patient's skeletal pattern. And it makes sense. The more acute that angle, the more forward-leaning the chin, the patients seem to respond better to functional appliances. So I'll go through my decision-making process regarding which, how I'm managing a class 2 patient. So this is Sarah. She's got a moderate amount of upper and lower crowding. She's full class 2, definitely mandibular retrusive. I like her nasolabial angle. I don't want to change that much. A pretty significant skeletal class 2. She's got that forward-leaning chin. Second molars are developing. And I'm getting a good vibe from her about her cooperation. Parents have got good control over the situation. She's motivated. If I've got all those, and she's at the beginning of her growth spurt, I'm leaning towards using a twin block. That's the appliance I'm most comfortable with, and I think I can get the nicest response with. The thing is, there are different ways to use a functional appliance, and I think it makes a big difference regarding what kind of outcome you get. Most textbooks will tell you to adjust the functional, when you're taking the bite registration, to take the bite registration at an edge-to-edge relationship, or sometimes even beyond an edge-to-edge relationship. The problem with that is that there's nothing holding those lower incisors back. And, you know, what's going to move faster? Lower incisors coming forward or the patient growing? And growth is a much slower process than proclining lower incisors. And I think if you're going to use a functional appliance like that, then maybe what Dr. Seki mentioned a couple of days ago is true, and you're going to end up with mostly dental changes. And maybe if you're using the functional appliance that way, maybe it's not much different than using class 2 elastics. But I think if you control the lower incisor inclination, like Mauro was mentioning yesterday, if you control the lower incisor inclination, you get to keep the functional appliance in for longer. You get to prevent that dental, you're treating it like a surgical case. So my goal is to procline the upper incisors, attempt to retrocline the lower incisors, and then use a functional. It's not the quicker way to do it. You definitely finish much, much faster if you take your bite registration at edge to edge or beyond, but you don't get the same outcome. One of our part-time faculty, Todd Rowe, always says orthodontics is like making souffle. It's not scrambled eggs. And I think that's the difference here. You can take your bite registration at edge to edge or beyond. You'll be done with the functional appliance in 6 to 8 months because the overjet's gone, and you're not gonna keep them in the appliance until they've got an anterior crossbite. So you end up taking it out, and the condyle is designed to get the teeth into maximum intercuspation. If the teeth are locked in and you've got overjet and contact between the upper and lower teeth, there's no reason for it to adapt anymore. So I take my bite registration with the upper and lower incisors in contact. And if I'm proclining those lower incisors, I keep modifying my functional appliance to maintain contact between the upper and lower incisors. And I'm going to show you cases where the lower incisors retrocline. You could do it using a TAD, but I think in a lot of cases where the geometry is right and the occlusal plane's in the right direction, if you get the lower incisors to contact the upper incisors, you can get them to retrocline without using a TAD. It's the same concept. So here you can see we've got a 2x4. We're aligning the upper teeth. We're giving her more overjet, and you can see here we've trimmed the. This is without the twin block, obviously. Every visit we check for centric relation, and we measure maximum protrusion. So what maximum protrusion tells you, it's an indication before you take your progress Ceph, it's an indication of whether the patient's posturing or whether the patient's growing. If the patient started out with an 8 millimeter overjet and a maximum protrusion of -2, and 3-4 months later, the overjet is down from 7 or 8 to 4, but maximum protrusion is still -2, then they haven't really grown. if the overjet goes from 8 or 7 to 3 or 4, but maximum protrusion goes to -4, -5, that is an indication that she is responding to the functional appliance. The posterior open bite's always nice to see, and once I get the AP correction that I want, I start trimming the twin block to allow the molars, the lower molars, to erupt to make up for the ramus height, the change in ramus height. So I want the molars to interdigitate in class 1 to help maintain that change. And she's got some crowding. She had some IPR. We limited the amount of proclination, but the proclination that occurred there is the result of relieving the crowding. It gets upper and lower fixed retainers. I'll show you superimposition. This is a year retention. And she grows a lot. And I think in patients where it's the right time and you get the right cooperation and they've got the right anatomy, I think these appliances can be a really useful tool. Now, if the patient's towards the end of their growth, or the child's talking to their mom, back at their mom a lot, or I see a lot of tension between the parents and the child, the parents aren't in control of the situation, or I'm worried about growth being close to being done and I don't want to waste time, I'll use a fixed functional appliance. I don't think they work as well, but if I don't want to risk losing that opportunity, I'm using a fixed functional appliance. So this is Audrey, and she's towards the end of her growth. If you look at her cervical vertebra, you could consider her finished, but we thought we'd give it a try, and we tell these patients, you know, we're going to do our best, and in my personal experience, I think 8, 9 times out of 10 it works out great. But if the cooperation's not there, or if the response isn't there, then we tell them that, you know, they might end up with needing to have a discussion about either upper premolar extractions or jaw surgery. And here's her hand wrist radiograph. We were hoping to see that she still had a significant amount of growth. Her sesamoid's there. You can see capping, and she's starting a fuse. So we're thinking she's towards the end of her growth. She might have a little bit left, but not much. And that's why we didn't want to risk any compliance. So we just had her posture forward just to kind of get a feel for, just like in a surgical patient. I'll often, whether it's a class 2 patient that's getting growth modification or if it's a surgical patient, I'm having the patient posture forward just to get a feel for what how the lips are going to drape in that position. And you're also looking at the transverse, because most of these patients, if you're gonna use a functional appliance, you need to expand the maxilla to adapt to accommodate that wider part of the mandible. So she gets a Herbst, and we're constantly maintaining contact between those upper and lower incisors. And you can see how those lower incisors start to retrocline. So I'll show you this stuff. And that's kind of where she starts. And every visit, we check to make sure we've got contact, and she'll get deeper and deeper as you advance with the Herbst or Mara or whatever you're using as a fixed functional. The more you advance, the more, if you maintain contact between the upper and lower incisors, you can get those lower incisors to retrocline. If you take your bite registration at edge to edge, there's nothing holding those lower incisors. They're going to come forward, and that's going to happen faster than the patient can grow. So we end up putting some bite turbos so she won't bite the brackets off, we bond the upper and lower arches. And that's where she finishes. In retrospect, maybe she could have used a little bit more uprighting of the lower molars, a little bit more expansion. Third molars are still developing. And she gets a pretty nice response, even though it was later in her development. And you can see the blue, the black is initial, blue is progress, red is final. And you can see between black and blue, those lower incisors actually uprighted. as we were advancing and maintaining contact between the upper and lower incisors. They obviously came forward because she had crowding, she had that curved speed. And if the compliance isn't there and the patient can't tolerate a functional appliance, we're taking out upper premolars. This is a patient that was referred to me from teaching practice at Harvard, and she had started treatment in the teaching practice with a fixed functional Amara, and the patient couldn't tolerate it, and mom was making a big deal. She ended up seeing me in the faculty practice. I told them I would have done the exact same thing that the part-time faculty had done. If she wanted me to treat her at this point, I was extracting upper premolars. I wasn't going to waste my time, any more time on something that she showed that she couldn't really tolerate. So we extracted upper premolars. So this is, I took the appliances off, took some new initial records. Still pretty much almost full cusp class 2. And we extract upper premolars and she finishes nicely. I think in these upper premolar extraction cases, to get them looking good, you really need a lot of torque on those upper incisors. So I usually use Warren springs for the majority of treatment. I've got partially activated Warren springs to maintain the torque of the upper incisors. The last thing you want on these patients is to just move the upper teeth, tip the upper teeth back to the lower. They just have that upper bi extraction look. Maintaining upper incisor torque is really important to get these cases looking nice with upper premolar extractions. And you can see here upper incisor inclination is maintained. And she didn't grow much, even though she was at her growth spurt, and she didn't grow as much as I was hoping she'd grow. Crowding is another important consideration because it can prevent you from being able to control that lower incisor position during your growth modification stage. And I'm going to cover this with a story about two sisters here. And they're actually more than sisters. They're twins that were treated in the clinic. Each one of them was with a different resident, but they had pretty much the same treatment protocol. But there was a difference. One of them would not let us extract teeth. And the mom stood by her, and I wish we hadn't budged. The second one was a couple of months behind her in treatment, and she let us take teeth out. So it's not often that you get identical twins with where you can treat them differently. This is one of those cases. So Camille, sorry for the photo, her head's a little bit tipped down there, but she has a facial asymmetry. Her chin is a little bit to the right. It's interesting that her sister's chin is to the left. Her chin's to the right. Full cusp class 2 on the left, half to 3/4 cusp class 2 on the right. And she's got a significant amount of upper and lower crowding. Wisdom teeth are obviously don't have room. Second molars are erupting. She's hyperdivergent. Lower incisors are at 90 degrees. They actually look pretty good, but she has a significant amount of crowding. So we told them we'll start out with some growth modification, but we said that growth modification is something we're doing to allow us to extract upper and lower premolars. So the goal was to get her to a point where the class 2 correction was achieved through growth modification, which would allow us to extract upper and lower premolars so we can get the incisors at a nicer inclination and reduce some of that lip strain that she had. If I don't correct the class 2 relationship with a functional appliance, then I'm locked into extracting upper bis and ending up with lower incisors that are proclined and chin-lip relationship that's not ideal. So if she gets a Mara, and she gets some expansion, you can see we're trying our best to maintain contact between the upper and lower teeth, but it's not always possible. If the occlusal plane and the depth of the bite aren't favorable, it's going to be very difficult to maintain contact between the upper and lower incisors, especially on these hyperdivergent patients. And this is one of those cases where I wish we had used a TAD like Mauro had mentioned yesterday. Anyway, at this point, we're talking to them about extractions, and mom is, I don't know if she had a bad day, but her and the daughter were completely against it, and they would not let us. And at that point, we're already in treatment, but they completely refused taking teeth out. And yeah, I wish we had stuck to our guns, because this is one that didn't turn out very nicely. And I think it's related to those lower incisors coming forward and getting her lower incisor. There's no room for those lower incisors. There's so much crowding in the lower that they have to come forward. We IPR'd, couldn't IPR enough to eliminate the crowding and maintain a good lower incisor inclination for her divergency. So she ends up rotating down and back, and then we're chasing the mandible backwards. And you can see there her vertical wasn't maintained well. Her lower incisors came forward. I don't like the lip strain that she's got. And the lower incisors didn't procline that much with the amount of IPR that we did. They're at 96 to IMPA, but they're pretty proclined for her divergency and for her face. And that's where she ends up, and I'm honestly not happy with her, with the way she looks. She finishes quicker than her sister, but I think her sister finishes better. So her sister on the other, so this was as we're finishing and detailing, and that's her, the day of debond. You can see the tissue's a little bit inflamed from the debond. The models look okay, but I'm not happy with her face. I'm not happy with that lip strain. And she ends up at 102, which is more than I'd like to be for her divergency. Now her sister, on the other hand, starts out the exact same way. Her asymmetry is to the opposite side. Her mandible's off to the left and lower midline's off to the left. Both sides are a little bit more class 2 than her twin. And but Sarah lets us extract upper and lower premolars. So we're using the functional, and then about 2/3 of the way we extract upper and lower premolars, and that gives us the room to upright those lower incisors. And she's still hyperdivergent, but we get a lot more chin projection. And part of that chin projection is some better vertical control, better she expresses some more growth in the anterior, and when the lower incisors are uprighted, it gives us better definition of the chin. And there are the two sisters, and you can see there's definitely a difference in their profile and their vertical control with the different treatment approaches. The next issue we were kind of torn on, and I'll show you a couple of cases that kind of got us thinking about this when we're treating class 2 patients. And I'll also talk about some unpublished work that we're submitting for publication right now. So I'll start with this girl. She started out full class 2, completely blocked out upper canines. She has a lingual arch. She has some mild crowding in the lower, but she also has a family history of sleep apnea. Mom has sleep apnea. We did a pediatric sleep questionnaire group of questions, and a lot of them were answered positive. So we were concerned about sleep apnea. I also think she has a nose that's not done growing. Obtuse nasolabial angle. So I wanted to give her some additional lip support. And that was a time where, we were getting, there was a lot of accusation being thrown around by the general dentist that orthodontists are causing sleep apnea. And we came across this study by Peter Nan that showed how functional appliances can help patients that actually have sleep apnea. It can improve their AHI. And there's also this study that showed that if you extract upper premolars and do nothing, this study basically just took upper premolars out, followed the patients up for a year with no intervention, compared them to a matched group that had no upper premolar extractions. And they found that the patients that had upper premolar extractions had less growth of the mandible and less counterclockwise rotation tendency for the mandible, which I thought was interesting. So that kind of got us thinking, both the profile concerns and the sleep apnea concerns got us thinking of trying to treat her, non-extraction in the upper, advancing those upper incisors, giving her a bit more lip support, and then using a functional appliance. Around the same time, one of our residents, Shema Tabari, was working on a research project that that looked at predictors of sleep apnea. So, and we also wanted to see whether or not there was a relationship between orthodontic tooth movement and sleep apnea. So what we did is, for a few months, everyone that started treatment got a sleep study. And we worked with Elliot Katz from Children's Hospital. He's a pediatric pulmonologist, and he read all of our sleep studies. And the idea was we included everyone. It wasn't just extraction patients. We also included non-extraction patients. The thought being, if the hypothesis is that retracting the upper teeth causes sleep apnea or airway obstruction, then the opposite should be true as well. If you're moving the teeth forward, then you should have the opposite effect. So this was a fishing expedition to decide what to focus on in future research. So we started out, anyone starting treatment, before they started, they got a sleep study. And we were trying to see whether or not there are any predictors of a high AHI. And we actually found quite a few. Maxillary arch length was a big one. Maxillary intercanine distance was a big one. Intercanine distance. SNB, the lower SNB was, the higher the AHI was. And there have been other studies that showed similar things. And the pediatric sleep questionnaire was predictive of sleep apnea and airway length. So we followed these patients up during treatment, and she tried as much as possible to include all of them in the follow-up. You'd think you'd offer patients like a free sleep study; they'd be all over it. But it's a lot of them had sleep studies where they didn't have enough hours to get a proper assessment of their sleep. A lot of them refused to do it again. They said they couldn't sleep properly with the monitor. So we ended up with a much smaller sample size for the follow-up. And here we looked at different cephalometric parameters. We looked at different model parameters. And we actually looked at AHI. A lot of this, the reason we were doing this is that a lot of the studies that look at extraction effects on airway, they're looking at the airway size. And the airway is not diagnostic of sleep apnea. You need a polysomnograph to diagnose sleep apnea. And there's the relationship between airway size, whether it's on a PAN, whether it's on a Ceph or a CBCT, is definitely weak. There is a relationship, but it's not a strong relationship. So when we followed these patients up, the only factors that we found that changed during orthodontic treatment that correlated with an worsening AHI or sleep apnea score were were maxillary arch length, so the distance between the molars and the incisors. When that distance between the molars and incisors increased, the AHI decreased. When that distance between the incisal edge and the first molars decreased, the AHI increased. And the intercanine distance had a similar, the mandibular intercanine distance had a similar relationship with the AHI. I was honestly going into this study being sure that we weren't going to find anything, and I would have been happy, publishing that. I was pretty sure we were going to go in there, look at all these measurements, and there wasn't going to be any relationship between changes in any tooth movements and change in AHI score. I was actually surprised that it was upper arch length on the models that was the only factor that was correlated, and we corrected for, we controlled for age, gender, BMI, and it was a pretty significant relationship between upper arch length and the AHI score, changes in upper arch length and change in AHI score over time. This was not a homogeneous sample. This was a fishing expedition to decide what to focus future research on. And I'll talk to you in a little bit about what we're doing now about this. So back to our patient. Second premolars are ready to erupt, and you can see those canines, upper canines, have nowhere to go. You see that obtuse nasolabial angle, that nose, and she's at the beginning of her growth spurt, and you know that nose is going to grow more. She doesn't have a favorable chin anatomy. Lower incisors are at 96, so I really don't want to see them come forward much, if any, if I have a choice. And so we decide to open spaces, advance the upper incisors, basically decompensate her, advance the upper incisors, make room for those canines to come in, give her a bit more lip support, and then use a functional appliance to get her lower arch to catch up with her upper. And then once we have enough clearance, we use Amara, and again we maintain contact between the upper and lower incisors to limit the proclination of those lower incisors. And she's in the Mara for close to a year. She obviously gets some expansion. And then we bond the upper and lower arches at this point. Canines are starting to erupt. They weren't exposed. Lower incisor here at the end of this is the day she was bonded, right at the end of the functional appliance phase, and the lower incisors are 95 degrees. I can't get that if I'm using rubber bands to correct the class 2 relationship. I'm getting retroclination of the upper incisors and proclination of the lower incisors. I have no way to control that with rubber bands, and I don't get the vertical control that I can get with the functional appliances, and that's why I think you get a better outcome with this way of treating the patient. And she gets a decent amount of growth. You see her nose grows, but her nasolabial angle is looking better. Here we're getting on the canines and finishing and detailing. And that's her finish. It's a fixed retainer on the lower. And I like her nasolabial angle. I think she has a better outcome than she would have had if we had extracted upper premolars. We don't have an alternate universe where we can compare, but I think her nasolabial angle turned out nicely. Lower incisor ended up at 95 degrees. Now this patient got me reconsidering my my position on the whole upper premolar extraction situation. He has an older brother that's on a CPAP. His dad is on a CPAP. During the consult, he was there, his dad, I wanted to do pretty much the same thing we did for the previous patient, advance the upper teeth. He has obtuse nasolabial angle. canines blocked out, retroclined upper incisors. There's plenty of room to advance those upper teeth. And we agreed that we were going to do pretty much the same thing that we had done for the previous patient, open spaces, and we were going to actually use a twin block once we had clearance and had advanced the upper incisors. After we agreed on everything, next time the patient comes in, mom's there, and she says, extracted, he's getting upper premolars extracted, and there's no reasoning with her. I told her I think I'd prefer to procline the upper teeth and set him up for jaw surgery, and she was not having it. There's no surgery. There's no growth modification. Mom decided he was getting upper premolars extracted, and I think at that point, maybe I shouldn't have, but I learned something from giving in to her, and you'll see how the case turns out because I was pleasantly surprised. So we took out upper premolars. The kid was a champ, finished treatment in well under 2 years. And this is the day of debond. What really surprised me is that he grew. His nasolabial, and again, upper premolar extraction cases almost all get Warren Springs with me. So he had Warren Springs for the majority of treatment to control the torque of those upper incisors. But he grew, and during treatment, I didn't really need to use any class 2 elastics. Nasolabial angle looks nicer, and he grew a lot. And I was pleasantly surprised. You see, I had I ended up advancing the upper teeth even though I extracted upper premolars. He was growing, and I just kept torquing those upper incisors. And that got me wondering, got me looking at my class 2 cases a little bit more carefully. And it also got me to work with another resident, Ashira Gendelman, on, this is his retention, these are his retention records. But we worked with Ashira Gendelman on going back and looking at our upper premolar extraction cases and comparing them to our functional cases, and looking at their airways and looking at the skeletal change that occurs during treatment. And I also started looking a little bit more carefully at my upper premolar extraction cases. And again, this is pure opinion / observation. I think once you start taking those upper canines back and on your upper premolar extraction cases, I think you start to develop, you get inclined planes where the patient starts posturing forward. I look for it, and I see a CRCO shift on these patients as you start to retract the upper canines. So maybe that's what's causing an improvement in the skeletal relationship. And this is different than the study that just took out upper premolars and did nothing. So this is upper premolars with intervention, where you start retracting the canines and bringing them into class 1. And I think once those upper canines start to come back, it's a little bit like what you see with a headgear. I don't know if people that have used a headgear have looked at this, but when I use a headgear, a couple of months into the headgear, you get a pretty significant improvement, but you take them back into CR and they're not there. The cusps, when the patient's transitioning from a full cusp class 2 to a class 1, you get a period where they start to develop a functional shift. Those inclined planes get the mandible to posture forward a little bit. And I think that's why patients on headgears do have a little bit more growth than untreated controls. So in this study, we looked at upper premolar extractions compared to functional appliances. We did an airway analysis, and we also did a cephalometric analysis comparing mandibular length, ramus height, A and B changes. All the skeletal measurements improved a little bit more on the functional appliance patients, but it wasn't statistically significant. The thing that was statistically significant was superior airway space and retropalatal airway space. Everything else was a little bit better on the functional group, patients in the functional group, but it was not statistically significant. The difference was not statistically significant. Superior airway space and retropalatal space was. And the reason we wanted to look at this was, Shaima's study, where we just looked at everything, all the types of movements we did in the clinic. We thought, what cases have a change to the maxillary arch length more than upper premolar extractions on patients with an excessive overjet? So that's kind of what Ashira focused on. Patients that had excessive overjet, class 2, and had upper premolars extracted compared to functional appliance treatment. And she matched the cases pretty well, age, gender, and growth status, and so on. And this was interesting. All the airway measurements were better in the functional group, but these two measurements were statistically significantly better. So maybe the growth advantage isn't as big as I thought it would have been. Comparing functionals, I thought you'd extract up, and I don't do upper buys a lot on growing kids. It's my last resort when I use all the other tools and the patient refuses jaw surgery. That's when upper buys come out. But maybe I was too hard on upper premolar extractions, because you can get, I think if you control the upper incisor inclination well, and you manage the vertical well, I think you can still get a significant amount of mandibular growth on these patients. The last patient I'm going to talk about is, and the last consideration I'm going to talk about is kind of relevant to this time that we're in, patient availability or doctor availability. So this is a patient, Selena, who she was 11 years, 7 months old. Primary concern was that upper canine that's blocked out. No significant medical history. History of trauma to her upper incisors, and that's related to the next issue, which is she lives on a 50-foot aluminum boat. Her parents are explorers, global climate expedition, and they told me that she spends most of her time crossing the Atlantic or the Pacific, and I'm not going to be able to see her more than twice a year. There's 1 year where I might have seen her 3 times, but that was it. And that affects what you can do. You don't want her having emergencies in the middle of the Atlantic Ocean. So that's their boat in the Arctic. She's in the late mixed dentition. Second premolars are developing. She's getting close to losing those E's. Second molars are close to developing, close to erupting. You can see she has a very sensitive profile. Retroclined upper and lower teeth. Normodivergent, very favorable chin anatomy. So retrusive upper and lower lips, retrusive chin. Both midlines are off to the right. The upper canine is more blocked out. She has a blocked out lower right premolar, and that's why her lower incisors are off to the lower midlines off to the right. Mandibular hypoplasia. She has a short lower face height. She's not that hypodivergent, but she does have a short lower face height. Class 2 molars and canines. She has an impinging deep bite, retroclined upper and lower incisors, and severe upper and lower crowding. And she's got undersized upper lateral incisors. So we have our work cut out for us, especially that she's telling us that we can't see her regularly. Now, in a normal situation, I'd have a 2x4, open spaces for those canines to come in, give her a little bit more, give her more upper lip support, open room for that lower right premolar, and go for some growth modification. I think she's lost a little bit of space on the right side. I'd be considering distalizing on the right side as well. But all of that's off the table because I don't want her with a broken distalizer or a broken 2x4. I guess we've all gotten a little bit better at managing these emergencies from home and having Zoom, HIPAA compliant Zoom meetings with the patient. But this was before then, and I now know that I can do a lot more remotely than I ever thought that I could do. But this patient was before that era, and this was my first experience with remote care. So we end up choosing to do it with clear aligners, and she signed I got her on the consent form. We added so many clauses to the consent form saying this is going to be an improvement. I treat a lot of patients with aligners. We do surgical patients with aligners, but this was out of my aligner, way, way out of my aligner comfort zone. But I also thought that, she's a really compliant girl. She's a really sweet girl. I thought that we could at least try our best to give her an improvement, at least try to get those canines in. I told them we'll shoot for ideal, but I seriously doubt we're going to be able to get anywhere near an optimal result if our hands are tied this way and we're only using clear aligners. So I asked for distalization of the molars on the right side, 20 degrees from 2 to 3 millimeters, as well as some derotation of the upper right molars. I wanted class 2 elastics from the upper right canine. I thought she was very lucky in that way. I thought she was lucky because the lower right premolar is, the lower right second premolar is blocked out lingually, and the upper right canine is blocked out buccally. And I thought that was very convenient. So I wanted her to wear rubber bands from the upper right canine to support that molar distalization, and to wear the rubber bands to the lingual of that lower second premolar so that as we're opening spaces, that lower second premolar can move labially. This ClinCheck, these groups of ClinChecks took a lot of work. And I'll show you the process of dealing with the technicians because they did not get what we were trying to do. And I asked for the upper and lower midlines to be moved to the patient's left as we advance the upper and lower incisors. And I asked for virtual bite turbos. I wanted virtual bite turbos that were changing as the patient's teeth advanced, because I wanted to use that kind of like a functional appliance where I was asking the patient to posture in that position with contact between the upper and lower teeth, but I wanted to give her a platform to bite on. So this is the first ClinCheck they sent, and you can see here, that tooth was there, I scanned it. But on the first ClinCheck, they just omitted that lower left second premolar. If you go with the first ClinCheck they give you, this is not fitting. This aligner will never fit. The other thing they did is they omitted this canine. It's there, but they got rid of it. And again, if you go with this, probably around aligner 10 or 15, the aligners will stop fitting. And on the left side, they give you this massive tooth that doesn't really, it gives the tooth room to erupt, but it doesn't, you can do better. And they finally gave me the tooth, but then as they get it to erupt, you have to pay attention with these growing patients or patients with teeth that are erupting. I want you to notice the neck of this tooth. As the tooth erupts, it gets skinnier. So right about halfway through treatment, these aligners will stop fitting because we all know that the unerupted part of these canines is much wider than what we see. And the technicians just don't get it. You tell them you try all sorts of ways to ask them to make the tooth get bigger as it erupts, and they say it's not possible. The only workaround that I've found is asking them to bring the gums down with the tooth. So tell them to assume this is the tooth, and then as it comes down, just bring the gums with it and don't try to erupt it because they can't, their algorithms can't predict the unerupted part of the tooth accurately. Here we're at plan 7, and I'm pulling my hair out because they give me a pontic in that area. They're not giving me the real tooth, and they're making room for it, but it's still not what I'm asking for because I can't use a rubber band for that. They end up giving me the tooth, but they wouldn't give me a cutout for a rubber band. They said the clinical crown was too short, so they couldn't give a cutout for a rubber band to be worn. The work around that ended up being asking them to forget about the cutout, just give me the tooth, show me the scanned part of the tooth, but make the clinical crown shorter, bring the gums up, and that's something they can do. So they can assume that the clinical crown ends here and assume this is gums. And what that does, it gives me this part of the tooth, the lingual cusp, for me to bond the button to and have her wear an elastic to that. So this was plan 8, and this is the one that we ended up going with. We're advancing the lower incisors, swinging the lower midline to the patient's left, distalizing in the upper, doing some sequential distalization in the upper, making room for those upper canines to come in. And she comes back about 9 months later, and this is where she's at. She's lost her baby teeth. She's got some improvement. That lower second premolar's in. The canines are in the arch. She's still about half cusp class 2 on the right side, maybe a quarter cusp class 2 on the left. And she's on aligner 41 of 54, and we decide to do a refinement at that point. The goals of the refinement were a little bit more distalization. The upper incisors were tipped to her right, and we wanted to upright them. And we wanted to refine some spaces for the upper incisor buildups. She also had a fracture of her upper teeth that happened on a stormy day on the boat, and she had chipped her tooth a while back. So we wanted to do a little bit of composite work on those upper incisors. So she had a couple of months of nothing, and they flew her in from Iceland to start the refinement. So between September and November, nothing really happened. This is her after the first refinement. She's starting to look a little bit better. Canines are class 1, midlines are a little bit closer, still has the tip issue with those upper incisors. Lower crowding's pretty much gone. And at this point, I build up her upper laterals for her, and we scan again for another refinement. I can't think of a patient we've treated that didn't need a refinement. Every Invisalign patient needs a refinement. If you're going to finish them nicely, they need at least one refinement, usually multiple refinements. And we decided to take our final records early, even though we had scanned for refinement. I wanted to see what the roots were doing. I wanted to kind of evaluate the changes that were occurring. She was a good grower. We lucked out with that. Upper incisor inclination actually looks pretty good. Invisalign sometimes struggles with that, but if you're proclining, it's better at proclining than torquing. The lower incisor is advanced, but her face could take it. Her chin could take it. She has a long nose and a long chin, and she's not hyperdivergent, and she could tolerate that, the advancement of those lower incisors. And this was at this point, we're at plan number 18. So these patients might take less work from you in the clinic, but it definitely is a lot more work a lot more time in front of the computer. And I was FaceTiming with her regularly, especially during the first round of aligners. In the second round, it was just, there was less rubber bands being used and less craziness going on. It was just finishing and detailing at this point. So we were trying to get the gingival margins a little bit nicer. We wanted to get the second molars, the torque on the second molars looking a little bit better. We wanted to get some better interdigitation. So this was the approved second refinement. We tried our best to over-treat those upper central incisors. And this is where she finishes. And she finished with a result that was better than I had expected. The conclusions are functional appliances are tools, and you could use them or misuse them. And I think it's a tool that we should all have in our toolbox because there are patients that can benefit from them. I think preventing dental compensation, treating these functional cases like surgical cases, controlling as much as possible the lower incisor inclination, like Mauro was saying yesterday, a TAD's a great idea for that. Sometimes you need to take teeth out to be able to control that lower incisor inclination. But I think it's key to getting a nice response with growth modification. It's the same idea that the tweed people had with headgears and class 3 elastics to upright those lower incisors. I think it makes a big difference. Vertical control and treating during the growth spurt. I think those are all factors that help you maximize the skeletal effect that you get during treatment. Decreasing maxillary arch length might have a negative effect on the airways. We're in the process of starting a longitudinal study now, taking actual AHI, like doing actual sleep studies at the beginning of treatment and taking them again at the end of functional appliance treatment versus upper premolar extractions. And based on our previous findings, we need to try to answer that question a little bit better. And finally, clear aligners can be useful in treating situations where patients cannot be regularly seen in person. And I want to thank the organizers once again for the invitation, and I want to thank all of you for your attention. Thank you.
Well, can you see me, Renato? I'm not sure.
Yes, we can see you, and if you don't mind, if Andrea is available, we can run the poll. It's just for just 2 minutes. So I will ask the cooperation of the postgraduate students to improve our initiative. So we would ask, are you planning to follow the webinars from week 7 and 8? So please answer. The second question is, how do you judge the selected topics of the webinars? I leave you a few seconds to decide. And then the third question is, how do you rate the discussion afterwards so that we can evaluate if we want to change the model of these webinars? And finally, would you consider to follow some selected angle webinars during the rest of the year? In a scale 1 to 4, what would be your intention in that respect? So after leaving the students the time to answer, I will hand the floor to the moderators to start the discussion. Thank you very much. Please.
Okay. First, thank you so much, Dr. Masoud, for this brilliant presentation lecture. And we know that this topic of class 2 treatment is always really interesting regarding the number of participants we have and regarding the questions we have. Many topics we have to discuss on. The first one is regarding the registration of the bite when you are making impressions for functional appliance. Could you comment on that?
Yeah, so I give the patient a mirror. If the upper and lower midlines are coincident with the patient's facial midlines, I show them where their upper midline and the lower midline is, and I ask them to posture with positive overjet overbite. I kind of show them where I want them to be with my hands. I want the midlines on, and I want the upper and lower teeth touching each other, but with overlap between the upper and lower incisors. And you're going to drive your lab person a little bit crazy in the beginning until they know how you like your functional appliances made, because they're not used to it. They're used to making your functional appliances with these big, massive blocks that make it very difficult for the patients to wear regularly. and they're used to making them edge to edge or at an anterior crossbite. But I'm asking the patient to posture with the upper and lower teeth touching each other and the midlines on. And I give them a mirror and I have them practice it a few times. And then I fill the sides with blue mousse if I'm taking a traditional impression, or I'll scan. And now we'll just have them posture in that position, give them a mirror, ask them to hold it. When I can see that they can hold it for long enough, I'm going in there and scanning on both sides, or just filling it with blue mousse. Yeah, that's
okay,
that's
right.
that. And then as the teeth change during treatment, you need to constantly modify the slope on the bite block. I modify the lower bite block slope and just add extra composite to the lower to maintain that contact between the upper and lower teeth if I'm proclining the upper teeth.
Okay, and you mentioned that if you are maintaining the contact between the upper and the lower incisor, you will not have proclination of the lower incisors.
It depends on the patient's geometry. You can't always maintain. There's some patients that are very steep, or they don't have enough overbite for you to be able to, when you advance them, you can't get that. But for the majority of patients, you can. And if you can maintain that contact, you'll often see the lower incisors, instead of procline the way you'd normally see, you actually see them retroclining.
Okay. And just to add a question, are you using the same protocol for MARA? Or is it just for functional, for bite block, twin block?
So the exact same concept. If I'm using a MARA, or if I'm using a Herbst, I'm using the exact same concept. Okay. Adding shims to it to keep that contact between the upper and lower teeth.
Okay, I'm pleased to hand over to you, David.
Well, thank you. We have a number of, I'm going to pick the first question that seems to be of interest to many of our attendees. Could you elaborate more on why you think removable functional appliances work better in your hands than the fixed functional appliances? Is this sort of an evidence-based concept, or is it just operator bias that may come into play with this choice?
I think it's a combination of operator bias and just personal observation. I don't have a study to prove that it works better, but I tend to see more dental movement. I think with a Herbst or a MARA, you tend to see the molars slip forward or tip forward. You don't see that as much with a twin block, because that lower arch length is locked. So I think you see less developing of that curvus spee and less tipping of those lower molars if you're using a twin block. And this is just personal bias and observation. Is I can keep the twin block in for longer, and to me, the longer I can keep the appliance in for, the less dental compensation that's happening, and I'm hoping I'm getting more skeletal change. And just again, this is just pure observation. They seem to look nicer at the end with a twin block than with a fixed functional appliance, and that's just my personal observation.
This kind of follows. I'll just do a follow-up if that's all right. Patricia, I have a follow-up that goes with the requester wondering whether you feel like you are actually with your functional appliances stimulating mandibular growth versus the evidence that we've talked about earlier in the week with Dr. O'Brien that we don't have studies that really, or evidence that really shows that there is a growth changes in the mandible, that the mandible doesn't really change in its size with the studies. Do you feel like you're getting actual change in mandibular dimension?
So all the studies that looked at early treatment consistently showed that there's no advantage over treating late. But those studies, again, they were never designed to show whether or not these appliances work compared to untreated controls. I think that table that forest plot that I showed for treatment during the adolescent growth spurt compared to untreated controls, that's from Kevin O'Brien's Cochrane review. It's there. If you look at the Cochrane review, that table's there. It just never gets mentioned for some reason. And it's that is the best evidence that we have for treating during the growth spurt. There are 3 randomized clinical trials that all show exactly the same thing, that if you treat during the growth spurt, there is, it's not a huge change, but there is a statistically significant improvement to the skeletal relationship. I also think most of those studies were not, we're taking a traditional bite registration. So I think that, I think you can get more than that. But even in those randomized clinical trials, which is the best evidence we've got, all of the ones that looked at treating, I couldn't find a single randomized controlled clinical trial that treated during the growth spurt that showed that there was no difference compared to untreated controls. The other part of that is, why do we treat a patient that has a lateral shift early? There's plenty of research that shows that the condyle adapts over time. If a patient has a lateral shift for an extended period of time, they develop asymmetries. The condyle does adapt to get the patient to intercuspate. There's obviously limits. The patient's genetics have will limit how much growth potential the patient has. But I think if the patient's in their growth spurt, there's a range and there are epigenetic factors that can determine whether or not the patient reaches their full potential. And there are things that we can do to control the vertical dimension, to create an environment that helps the patient reach their genetic potential of how much that mandible can go. Obviously, there's some patients that need jaw surgery because their jaws are so small and they don't have the potential to fully correct a significant discrepancy. But I think the majority of our class 2 patients, there are a lot more patients that get sent to surgery than necessary, I think.
I think it's a great answer for the many residents that are listening in on the program to try and understand that controversy. And I think that was a very, very good answer, Mo.
One last thing is, there's a researcher named Dan Lieberman. He's at the Peabody Museum. He's an anthropologist, he's a physical anthropologist. And he publishes in Science and Nature and stuff like that. So he doesn't publish in orthodontic journals, but some of his papers actually have cephs. And he has a really interesting study that kind of highlights these epigenetic factors that influence mandibular growth. He takes pigs and he gives them fresh fruit and takes another group of pigs and gives them fruit that was put in the microwave. And these are all siblings, pigs that are litter mates. And the patients the pigs that are on microwaved fruit had mandibles that were 10% shorter than the ones that had fresh fruit. So that shows that there are epigenetic factors that do influence the expression of an individual's growth potential.
Thank you.
Yes, thank you. Now we can go a little bit faster because we have a lot of questions to answer. It's regarding the treatment with 4-by extractions. Would you consider doing the 4-by extractions before using the MARA, while you are not leveling and aligning before using MARA?
So I try not to. There are exceptions, but I try not to bond the lower arch, because once you bond the lower arch, even if there's a little bit of crowding, those lower teeth are going forward. So I want to not bond the lower arch, and that allows me not to have to deal with issues like tooth size discrepancy. If I bond the upper and lower arches, I'm having to deal with whatever tooth size discrepancy the patient has. Those lower incisors are coming forward with the night-tie wires. It makes it a lot harder to prevent dental compensation. If those lower teeth are crowded and I'm using the appliance to try to retrocline the lower teeth, I don't care if they get more crowded. If they get more crowded, I'll take teeth out later on. I don't have a problem with that. But I want to retrocline the lower teeth as much as possible, let them crowd, because I want to maximize the time that I can keep them in a functional appliance and try my best to maximize the skeletal response.
Yes.
Okay, here's a question that several people had. First, I thank you for your lecture. Why wasn't the Mara used from the beginning in the case with the upper threes impacted? Wouldn't the headgear effect have helped the distalization of the upper molars?
Are they referring to the last case, or the one with the bilateral, the girl with the bilateral impacted canines?
Yes, that one.
So I didn't use the Mara from the beginning because there was no room to advance her, and I didn't want to take her beyond edge to edge. So okay. I wanted to maintain the contact because she's starting out at 96 degrees with an IMPA of 96 degrees. If I put her at edge to edge, lower incisors are going forward. So I created an environment where A, the canines could come in, and B, I could start using a Mara and maintain contact between the upper and lower incisors. And to be honest, open coil did cause a little bit of derotation and distalization of the molars. You can actually see the molar relationship getting a little bit better even before we put the Mara in because of that open coil.
In that same type of case, just to follow up in that same type of case where there's third molars developing nicely, would you ever consider extracting upper second molars to facilitate the headgear
Yes.
effect of the Mara on the first molars? Have you done that and found that to be an effective strategy?
I think it makes sense. I know people that do that. I haven't had the guts to do it. It's nothing wrong with it. I don't feel comfortable doing it, but it makes perfect sense. And upper third molars, unlike lower third molars, upper third molars, they come in pretty reliably. I just haven't done it, but I agree it makes sense. I'm more likely to extract upper wisdom teeth on someone a little bit older and distalize, but extracting upper second molars does make sense. I just haven't done it.
Thank you.
Yes, I have a question from a professor in France, in Marseille, who is Michel Legal, and he asked, the case with no space for the upper bicuspids, why you don't extract the second bicuspids? You're not used to extract the second bicuspids, maybe?
No, I don't have a problem extracting second. I think there's some situations where I'll intentionally extract the second bicuspid and put open coil to help make room for the canine and distalize the first. If I'm extracting upper premolars and the canine's blocked out, I'll often extract the second premolars rather than the first bicuspids because I like the anatomy on the first premolars. It allows me to retract the upper first premolar without taxing my molar anchorage. I actually do that a lot. It's just that on that case, I wanted to advance the upper incisors. I didn't want to correct the class 2 relationship with upper extractions. I wanted to get as much proclination of the upper teeth and as much advancement as I could of the lower arch. But yeah, if I'm extracting upper bis and the canines are blocked out, I'll often extract second premolars. I like that. I like that a lot, actually.
This question also shows a lot of interest, and it's related to long-term stability. According to a few studies, long-term class 2 correction does not seem to stay stable. What is your opinion? And do you use different mechanisms to stabilize the class 2 correction in high-angle cases versus low-angle cases? Perhaps in a low-angle case, you'd use an anterior bite plane as part of your armamentarium, and in a high-angle case, maybe a full coverage, a splint. Is that part of the goal, and do you agree about the stability issue?
I spend a lot of time checking CR, and when I was starting out, I had a lot of influence from Paul Regali, and I for a period, I actually would take away the lower component of the functional appliance and leave the upper component as a splint. So if it was like an acrylic splint Herbst or a twin block, I would keep the upper occlusal coverage and get rid of the lower and let them go for a visit with no lower component, just to see whether or not they drop back or how much they drop back. I think if you're careful, and it's, the same goes for a headgear or forces or rubber bands, you really have to look for CR. And there are patients where, you know, you're close to the end of treatment and you really look for CR and you see like a 2 millimeter CR-CO shift and you end up having to put a forces in or something just to get rid of that CR-CO shift. And we've all been there. I think if you're careful at looking for CR, I think they're pretty stable. I think, you know, everyone has, you know, a case that they remember where they came back and they were like, you know, they dropped back to 2 millimeters, class 2 or a quarter class 2. I don't think it happens often, but once in a while you get those, but I don't think they happen any more frequently than they do with any type of treatment type, as long as you're checking for CR. I don't use a functional appliance in retention. If the patient started out shallow, I might use a full cover. I might use an Essex retainer. If they started out open or started out shallow, I might use Essex retainers just to kind of keep them deep in the front. I personally, unless they started extremely deep, I don't often use an anterior bite plate long-term for retention. I don't like the effect that you get long-term where the molars are up and they kind of rotate down and back on you. I want to try to get forward rotation on most class 2 patients. But yeah, once in a while, I mean, I've used an anterior bite plate for retention, but very seldom.
Thank you.
Now we have questions with your the research you have done, you are doing for sleep apnea treatment. During the study for the sleep apnea, did you measure the AHI before and after the treatment and compare?
Yeah, so the longitudinal study that we just did for every patient that was getting treatment, we were taking AHI before and we were taking AHI after. And that paper is being reviewed right now. Yeah, so we did AHI before and after. That longitudinal study that we did was not looking at air. We did measure airway, but the primary outcome we were focusing on was the AHI. And it did get a little bit worse when the maxillary arch length decreased. I wasn't expecting that.
In this research, did you compare the skeletal discrepancy, skeletal vertical discrepancy with your with the patients? Did you compare it or not?
Yes, we did, and when we looked at it cross-sectionally, there was something there. So when we looked at it cross-sectionally at the beginning of treatment, the patients that were more class 2 had higher AHIs.
Yeah.
But when we followed them up over time, the change in the skeletal relationship, again, this was our sample, and this was a fishing expedition to kind of decide what to focus on after that. But we didn't notice in our sample. It doesn't mean that it's not there. We might not have changed the skeletal relationship enough on enough of those patients to find statistical significance. It doesn't mean that there's no relationship. But we couldn't, in our sample, find a relationship between the change in the skeletal relationship and a change in the AHI.
David?
We probably didn't have enough patients where we changed the skeletal relationship. That's my guess.
This is
thank you.
Probably, I see Renato on, and I don't know.
Yes, Renato is here.
the hammer, the last question, but ties in with the AHI, the measurement. There's a couple of questions about how did you measure that arch length, and is arch length, in your opinion, a more significant factor than, say, expansion, maxillary skeletal expansion, when it comes to reducing the risk of AHI increasing?
I thought that we would find a relationship with intermolar distance. So, you know, that's what I was expecting. We just looked, again, we did it. This was just a kind of a preliminary pilot study to see if we could find something to focus on. And the upper arch length was the one that we detected in that sample.
Very interesting. Renato, I turn it over to you.
Very much. Renato, I have just a comment from a participant. May I, just a small times, really. Thank you very much for the presentation. I have a question. If we will be able to get the recording of the webinars, which we were not able to watch.
That is a very good question. I had this type of emails all the time, and I want to make clear, as a platform, for GDPR reason, we cannot keep recordings. Therefore, we cannot send recordings, but we send the link to every speaker so that the following day he can download his own or her own presentation. So the request should be made directly to the speaker, not to us, because we cannot keep a recording. Maybe in the future we will, but not at this point. So we, as the platform and the initiative, we do not have the recording of all the speakers, but all the speakers will have the possibility to download the recording, so you can ask them. And the recording will be canceled from the Zoom platform after 24 hours. Because otherwise we would need the permission of all the patients, and it would be very complicated according to the EU GDPR.
Okay, thank you for the participants.
Okay, well then, it has been a great week. So I hand the floor over to Anne, but before, I want to remind you that at 7:00 p.m. Central Eastern European Time, we have tonight the webinar that we organized with the European and American Academy of Aesthetic Dentistry. And Greg Kinzer, great prosthodontist from Seattle, will give the lecture tonight. Do not miss it. It's going to be a great presentation. Anne, please.
Thank you, Renato. And thank you, Patricia and David, for job well done moderating. Lots of nice, interesting questions. And Mo, thank you very much for your presentation. So we closed the door on class 2s for the week, and we're going to turn our attention towards craniofacial growth, some cleft lip and palate, some eruption disturbances, and auto-transplantation. On Monday, we've got Dr. Pierre Rank talking to us about normal and abnormal dental facial growth. Then on Tuesday, we take a trip to Denmark to spend some time with Dr. Bektor, and she's going to talk to us about disturbed tooth eruption. From there, on Wednesday, we get to go to my hometown, Boston, with Dr. Carol Ann Trotman, and to Chapel Hill, North Carolina, with Dr. Timothy Turvey, an oral surgeon. And the two of them will talk to us about facial cleft and craniofacial update on orthodontics and surgery. And then lastly, on Thursday, we are going to go to Poland with Dr. Zakroska, I hope I said that right, with autotransplantation of developing premolars to the anterior maxilla, an orthodontic perspective. So next week should be a very interesting and varied week. I want to wish those mothers in the group an early happy Mother's Day on Sunday, and everyone have a great weekend and stay healthy and stay safe. Thank you.
Arrivederci.
Hello, bye-bye. Bye.
Thank you. Bye.
Thanks, Renato. Thank you, everybody. Thanks, Diane.
Thanks, David.
For moderating.
Thanks,
Appreciate
David,
it.
for
Thank you.
sharing.
Bye-bye.
Bye.